want to recommend exclusive breastfeeding for this first 6 months of life. They say human milk is the best nutrition, bless you. As you have seen, for those of you that are live in clinical, especially on postpartum, we have lactation consultants that come and help the moms as they're learning to breastfeed. About 76% of moms try to initiate breastfeeding after birth, but only about 40% still are breastfeeding at 6 months. So a lot of times, some cultures will believe in what they call las dos cosas, which means they combine breast milk and formula. But again, just kind of knowing that if you're not pumping, you're not going to get adequate milk supply. So we want to make sure that they understand that need to have the frequent pumping. So you can see all of the different benefits here on the screen of breastfeeding. When we breastfeed, again, it's the right temperature, right? It comes right from the body. There's no need to warm it up. There's no need for a bottle. There's no need for any kind of packaging. If someone were to breastfeed instead of formula feed, we could save $13 billion a year if moms were able to breastfeed for the first 6 months. A lot of times it could be cultural influence, so if the culture believes and supports breastfeeding, it could be socially, if it's acceptable. Nowadays, I feel like it's much more accepted practice to, say, breastfeed in public than maybe 20 years ago. And also if the support of the partner is there, because it does require a lot of work. There are some moms that we don't want breastfeeding. So you can see on the screen things like if they have an active HIV infection. And we say this in developing countries, right? So if you're in sub-Sahara Africa and there's no formula store to go to feed your baby, and the mom has HIV, that they have to feed them, right? But we're talking about in developing countries, because the benefits of breastfeeding aren't going to outweigh the risk of contracting HIV at that point. Again, like something like brucellosis, again, infection from unpasteurized dairy. So we see that sometimes in our Amish population or some of our farming areas. And again, you can see, obviously, drug usage, things like that. So lactogenesis, our prolactin levels are highest the first 10 days of the after birth. So as the milk is removed and that breast gets emptied, more milk is going to produce. If there's incomplete removal of the milk, so if the breast doesn't empty completely, then they'll have a decrease in their milk supply. Different things like thoughts of their baby, sounds of their baby, smells of their baby can elicit the mom to have milk ejection, even the baby crying. Alcohol, stress, and fear can inhibit the milk letdown, so again, we just want to make sure that we cover that with mom as well. The benefit also, as they're breastfeeding, oxytocin is released naturally, so again, causing that uterus to contract and then thus reducing the risk of postpartum hemorrhage. Sometimes they can have painful contractions though, so just let them know that when they're doing it. So the first couple days, they're gonna get this kind of yellow, you can tell by the coloration here of that colostrum in the first couple days there. It's a yellow rich fluid in antibodies, high in protein, and it helps to establish the intestinal flora of the newborn. The composition of milk changes though, right? So when we see fore milk, which is the beginning of the milk production, to the hind milk or the end of the milk production. So as they're pumping, that fore milk is low fat and the hind milk is high fat. So sometimes we'll see, like in NICU babies, we'll tell the mom to pump first, and we'll save that milk for later when the baby's a little bit bigger, but we'll give them more of the hind milk to kind of give them a little bit more fat at the beginning. So we also want to make sure moms are feeding completely, again, through the emptying of the breast, because again, that denser calories are at the end of the feed. So we want to make sure baby gets all of that. Engorgement usually happens within the first 3 to 5 days. We talked about ways last week to decrease our milk supply with our cabbage leaves and things like that. Again, if the milk is not removed, the supply will diminish. So why do moms stop breastfeeding, right? So again, those baby-friendly hospitals that we talked about last week, training everyone, making sure they're, having the baby's room in, no pacifiers, lactation consultants, avoiding nipple confusion, things like that. But sometimes, moms, if they're not properly feeding or positioning the baby, they could have sore nipples. Again, helping them with that to, like the lanolin cream, so they're always asking, is it safe for my baby to feed if I put lanolin on? So yes, there is not any problem with that. So we want to make sure that we cover that with them. We also want to make sure the baby's ready to feed, right? So they'll start to put their hand in their mouth, they'll start to root. Again, they'll start to kind of show you that they're ready to eat. You can see kind of the top pictures there. When they start to really cry and work themselves up, it's hard to get them to calm down enough to get them to feed. So sometimes they can have difficulty if they wait too long to feed the baby. And we usually start to initiate breastfeeding within that first hour after birth. Again, many different positions that the mom can have. The football hold, so again, having the baby under the arm, modified cradle, side lying. Again, the biggest thing, supporting, with pillows. So again, if mom's holding cradle, it's hard to keep your hands in this position the whole time, right? So they have like those nice, like body pillows and things like that to try to help. Even folded blankets if they don't have the fancier pillows. But making sure that the baby's body is in proper alignment. Again, we want a good latch, so that seal between the mouth and the breast, that suction is what's going to remove the milk. Sometimes moms will start to manually express their breast before feeding the baby. Again, it kind of gives the baby a hint like, oh, this is what I'm supposed to do to feed now, right? So they can just have a few drops just to kind of lubricate that nipple. And again, holding the breast like a sandwich when they're giving it to the baby, parallel to the infant's lips. It shouldn't be painful. If it is, they can use a finger to kind of break the baby's suction and then reapply the baby's latch during that time. So we want to know how often should we feed, right? So there's many different ways. You'll see at like Sumo, we had a little log sheet where they could write down how much the baby ate or how often. There's even apps on their phone because again, as moms start to get sleep deprived, right? Waking up in the middle of the night, which breast did I give them last time, and that sort of thing. We want to make sure that we are kind of keeping track and alternating which side they're feeding on. Having them eat about every 3 hours, so we don't want them to go long stretches of time without eating. I know they want to have them feed on demand, but again, if a long period of time has stretched, we have to make sure that we feed the baby. As they grow, they will decrease that length of feeding because they're going to be able to get more and suck more out during that feed. So a lot of times we don't say necessarily to set the number of minutes, so like don't definitely feed them for 15, but look for cues like the baby's sleep, your breast feels soft, that their swallowing is slowed down, things like that. We're looking at their urine output, right? They should, if they're getting enough in, they should be getting enough out, and they should be gaining weight. So we want to make sure that we are monitoring that as well. If moms are going to hand express any kind of breast milk, again, they want to make sure they wash their hands. Sometimes even applying a warm towel prior to help with that milk production will get that milk be able to be expressed. You want to pump, maybe baby feeds on one breast and then you pump the other breast again and then switch the next time around. Hand pumps are very cheap, but they do require a little bit more effort by the moms. So a lot of times you'll see that you'll be able to get like hospital grade pumps. Sometimes insurance will cover them, but they're very nice. When we think about how to keep it, right? So breast milk itself, freshly pumped, like it says, you can leave it room temperature for 3 to 4 hours. So if they pump it and set it on the counter and wait until the next feed to feed the baby, they can use that. If you put it in the refrigerator, it's only good for 72 hours, and then you have to throw it out. And I know it's like everybody calls it liquid gold, right? But you have to throw it out. A lot of times we recommend if they're going to store the milk that they pump. Sometimes there's little containers, like in the NICU we used to have little screw top containers. Some of the breast milk kits have like little bags that they can store the milk, but if they put like 2 to 4 ounces of milk in a storage bag or a storage container and then freeze it, that way it's easier if you're going to use it to just defrost a little bit at a time. And you don't want to fill it completely full to the top, again, to allow for proper freezing expansion and then when it gets thawed out. But if it's in the freezer, a regular freezer, like in your refrigerator freezer, right, you can store milk for 6 months. You can't refreeze it if you thaw it out, okay? So if you took a package of milk out, warmed it up, and then didn't use all of it, you can't refreeze it, okay? You have to throw it out once you thaw it out. If you have the baby and you're feeding the baby, and this is the biggest, I even had this argument with my sister, but you feed the baby from a bottle, you have to discard whatever they don't eat, whether it's formula, whether it's breast milk. The risk of bacteria growth on that, even if they take it and stick it right back in the fridge and then try to reheat it later, I know it's very expensive, especially with formula, but you have to throw it out. And then anytime you were to thaw out the milk, it's only good for 24 hours, so it's not like a normal fresh pumped milk. So you want to make sure that you only have that used for 24 hours. All right, so what can you take and still breastfeed? So if you're on methadone, yes, you can breastfeed. If you're on Subutex, yes, you can breastfeed. Different medications, like for example, Sufedrin, so again, if they get a cold or something like that, can actually decrease milk supply, so knowing that. You can see some antidepressants, like sertraline, is safe for them to have, but then fluoxetine is not, right? So again, just knowing what they can and cannot take. Alcohol passes freely from blood to breast milk, and it can take up to 90 minutes to reach a peak level. So if the mom drinks more than 2 drinks, 2 alcoholic beverages, they should not breastfeed for at least 2 hours. So sometimes you'll hear people say that they pumped and dumped, but pumping and dumping does not accelerate the removal of alcohol from the breast milk, okay? It's still in your blood, so it's still gonna pass through. So you have to just wait the amount of time in between. Smoking also impairs breast milk, so the nicotine gets transferred to the infant in the breast milk. So if you are going to breastfeed, if you smoke, you should wait about 2 hours after that smoking to feed the baby. Caffeine also passes through to the infant, especially in a preterm infant, that could impact them and accumulate in them very quickly. Be cautious of herbals. So there's lots of like breast milk production cookies and teas and all this stuff, but again, they're not regulated by the Food and Drug Administration. There's no controls on them. We don't know a lot of the side effects, so just use caution when using herbals and other products. Sometimes moms can get mastitis, so an inflammation. Remember, itis means inflammation of the breast. So they could have fever, chills, body aches, headaches. We see this from inadequate breast emptying. We see this from plugged milk ducts. So they may have sore, cracked nipples. Again, remember, there has to be a way for the bacteria to enter into the body, right? So that bacteria gets in, and then we have that staph or strep or E. coli are our most common bacterial agents. So they're going to get treated with antibiotic. They can have ibuprofen for pain. Again, we just want to have them get treated with that. With formula, again, there's so many different brands, Gerber, Enfamil, Similac, even store brand names. There's different kinds too. So if a baby has a milk allergy, they may put them on soy, or even some of the other formulas like for Spit Up, for example, like there's Gerber Gentle that's out there. But if they're spitting up, we first want to make sure they're not overfeeding them, because sometimes they're giving them too much, and that could be why they're spitting up. So again, we want to just ask clarifying questions before that. Commercial formula has all the nutrients a baby needs. So there's no need for supplementation, there's no need for extra iron or anything like that. It's all in there. And they shouldn't start any kind of complementary feeding. Like they shouldn't be giving them cereals until they're 4 months of age. Okay, so a lot of times you'll hear them say, oh, just throw some cereal in the bottle and, you know, cut the nipple wider, you know, but we don't want to do that until they're 4 months of age giving them cereal. Fruit juice is also not recommended before 6 months of age. So again, we don't want to give them apple juice or things like that. Now you will see in practice sometimes if kiddos are suffering from really bad constipation, we may do like a water or fruit juice dilution, but again, a provider would tell them that with their baby, so we don't want to encourage them to just give the baby that juice. We want to advise never to prop a bottle. Again, you'll see, I mean, just Google it sometimes, you'll see these contraptions people set up so they can just have this bottle there and the baby's just like underneath it feeding, right? But if you're not there to take the bottle out as the baby's starting to choke, more fluid is going to flow and the baby could aspirate, things like that. We also don't want them to go to bed with a bottle. You know, as they get a little bit older, they will, so cute, you get the little cute pictures of them holding their own bottle, right? But as they go to bed with a bottle, one, it gets them used to the bottle right before bed, and then two, the milk pools in their mouth, and as they get teeth eruption, it can cause baby bottle tooth decay. So we don't want them to be taking a bottle to bed. We also, if they use normal city water, there's no need to add extra fluoride, right? So if you have the type of formula that's powder and you have to mix it with water, if you use your tap water and it's not like well water, it should have, is all city water is automatically fluorinated in the water. So you don't need that special like nursery water. Now if you have a well source or an unclean water source in your home, yes, then use your special water. But again, too much fluoride can actually stain their teeth when they're developing. All right, so when teaching a new mom how to breastfeed, the nurse should include which instruction? Wash the nipple with soap and water twice a day. Begin nursing with the right breast every feed. Slide a finger into the mouth to break suction before removing, or supplement the baby with formula until the milk supply is established. C. All right. Now there are times, of course, when we have our special babies, our high-risk newborns that are born. We'll talk a little bit about them. So when we look at the babies, right, so these are babies that, like it says, has a higher chance of morbidity or mortality, these kinds of things, right? So maybe chemically, like hypo or hyperglycemia, maybe they have hyperbilly or respiratory distress or hypothermic issues. Maybe they have an injury during labor or birth that happened to them. Or maybe it's something congenital, like a cleft lip or a cleft palate or a neurotube defect or a cardiac defect or even a GI defect. So a lot of times it depends on the viability of the baby. Again, when we think about this, the baby born at, you know, we had one yesterday that was, they said 19 weeks. The mom didn't know she was pregnant, the baby was born. The viability of that baby at 19 weeks would have been practically non-existent. But again, it can, we want to look at that. We classify them by their birth weight, their gestational age, and then those physical problems. Some injuries are avoidable. Again, we can look at ultrasounds to detect. Some are unavoidable, right? If they have a prolonged labor or an abnormal fetal presentation. So when we look, sometimes they can have skeletal injuries like a skull fracture or even a clavicle fracture. So we talked about doing that Moro reflex and that one arm's not reacting. That's kind of telling us that we can have an issue with a fractured clavicle. They can also have a plexus injury. So again, as they get shoulder dystocia and they're pulling and pulling, again, that neck gets stretched and that nerve can get aggravated and they can have an issue there. They can have palsy that happen. Stretched nerve recovery sometimes can take 3 to 6 months. So again, these babies will be monitored during that time. And if the nerve was completely avulsed, it can have permanent damage, right? So after 3 months, if they're not showing improvement, sometimes they do need surgery. Sepsis, so again, you can get the identification of the bacteria that is causing this through a blood culture, CSF culture. Sometimes even a urine culture may show you what's going on with the baby. But again, we want to try to identify what's happening. So some early signs that you'll see, like it says here, lethargy. The baby's just kind of laying there, they're not eating well, they're crying. About half of those babies will die. Okay, so again, we want to try the earlier the better to identify it and get it treated. Late onset, so something that happens later on, like you can see 7 to 30 days later, is usually either hospital or community acquired. So again, we want to use good hand hygiene. Good hand washing is one of the most effective ways to prevent any kind of acquired illness there. But again, we want to make sure that we're watching, changing equipment for policy, following with precautions, making sure that they get antibiotic treatment if they need it. So the acronym TORCH, you'll have that for maternal infections to help you remember. Toxoplasmosis, other, rubella, CMV, or herpes. When we look at this, other could be things like the parvovirus, West Nile, varicella, measles, mumps, syphilis, things like that. Pregnant healthcare workers, so as you go, women into the field of nursing, if you have someone with CMV or rubella, you might want to take care of that patient while you're pregnant, and again, following your standard precautions. Substance abuse, so again, you can see some of the substances on the screen here that can cause issues during pregnancy. The degree of the withdrawal is related to, one, the amount of drug that they took, right? The length of time they were taking it, and the drug level at birth. So if they did a lot of drugs right before birth and it's still very high when they come in, the chances of withdrawing the baby are very high. Sometimes they can't show they don't show withdrawal signs for 7 days. So again, if we think about it, this baby's already kind of predisposed to a chance for neglected abuse based on the fact that mom was abusing while pregnant. If they use tobacco, they're 25% more likely to be preterm, low birth weight. Their risk of SIDS is double, and they have vasoconstriction in their brain development. With alcohol, we see fetal alcohol disease. We can see learning disabilities, very common. With marijuana use, we can see a shortened pregnancy, IUGR, learning and behavioral deficits. With cocaine, a risk of placental abruption, low birth weight, preterm birth, and with methamphetamines, we can see preterm birth, behavioral problems, placental abruption. Again, a lot of times we'll start to see withdrawal, usually within the first 2 to 3 days. Usually we start to see things like jitteriness, a persistent high-pitched cry, sneezing frequently, seizures, things like that. So again, they'll rate the baby and then adjust the treatment accordingly. So we used to use the modified Finnegan scale, where it used to look at things like, was the baby disturbed and had tremors, or did they have tremors when they were undisturbed? Were they sneezing? Did they have a lot of excoriation? Did they not sleep? Like, these babies would not sleep for their 3 hours in between their feeds like a normal newborn. They would have poor feeding, and maybe their vital signs were off. So again, however you can identify, now they're using a lot more of the Eat, Sleep, Console, which they've seen more results with that one. Remember too, our babies with the RH incompatibility, again, mom is RH negative and baby is RH positive, so this antibody's attacking. So we want to make sure that we identify that and treat. So again, you can see kind of from a pictorial standpoint where mom produces the antibodies in the first pregnancy, and a lot of times we see more of that erythroblastosis fetalis in the second pregnancy. Moms can also have what's called an ABO incompatibility. So if mom's blood type is O and the baby is A or B or AB, again, you can see that having some issues with the antibodies transferring over as well. Those babies, a lot of times, are ones that need phototherapy. So we have 2 different types of jaundice. So we have our physiological jaundice. This is going to occur in about 60% of those newborns, and usually the preterm babies. We'll start to see it peak again As for those of you that were on the floor with me when we did our 24-hour testing, we do the TCV to try to identify this and catch that early, right? And it'll start to decline over the next 5 to 10 days. And then we also have pathological jaundice. So again, you can see some higher risks for those babies there. A lot of times this is due to the blood incompatibility and hemolytic diseases. What we want to do is identify that bilirubin so that it doesn't progress to encephalopathy. So again, as that brain or the bilirubin level gets higher, they're at risk for kernicterus and that brain damage. We also have our babies that are born of diabetic mothers. Again, we talked about why we screen the moms with that glucose test. But those babies are at risk to be macrosomic, so larger babies. They're at risk, obviously, for birth injury, either too large to fit through the birth canal or if they have to get sectioned. And then hypoglycemia, their sugars drop. Cardiomyopathy, and those babies can also have hypermobility. Some of our infants, especially if they're preterm, they're going to need to be fed through an NG. So again, remember measuring from the nair to the earlobe to the midpoint of the xiphoid and abdomen for our proper measurements. And there's different feeding NG tube size, again, depending on the age of the baby. Some of the babies too are fed OG, so again, depends on if they need respiratory support or not. They may be gravity fed, so where we put a syringe up and just kind of let it go to gravity. We don't usually use the big gravity bags like you see with adults, especially in our babies. Or they may be put on a pump. So if it's a real thick feed, sometimes like 24 cal or higher, we'll put it on a little syringe pump and it actually pumps through the NG feed that way. A lot of times these babies are too weak. They can't coordinate their suck and swallow when they're little. I know for a couple of you that I took through the NICU yesterday, you can see some of those babies that had the NGs in there. Our preterm infants, again, they're subject to a number of different factors, right? Whether it's respiratory or cardio, temperature. Again, when I took a couple of groups down through the NICU, they were in the isolettes. Again, we have that their temperature and their humidity is programmed in there because they don't have that brown fat to help them, right? So they don't have the ability to regulate their temperature. They're also prone to infection. Again, a higher risk of things like neck and things like, we'll talk about it, I think it's on the next slide. So some complications, respiratory distress. So again, when these babies are born, they maybe lack surfactant or different things that could help them when they're there. Also in the respiratory field, the risk of BPD, so bronchopulmonary dysplasia. So again, when the premature infant has to have oxygen therapy, if they get too much oxygen or more than what they need, it can cause remodeling of the lungs. So they could have problems with that throughout life. They can also have retinopathy of prematurity. So again, a disease of the eye. So again, we use this oxygen to try to help them, right? But sometimes it can cause scarring and retinal detachment. So again, we want to make sure that we're only using oxygen when necessary and only the minimum amount that we need. They can also have necrotizing enterocolitis or NEC, again, where a portion of the bowel dies. And so sometimes those babies need to have bowel resection. Sometimes they'll end up with short gut syndrome when we have that there. And then, again, some of our cardiac defects. They may also have different intraventricular hemorrhages. So again, they'll grade them 1 through 4, where 1 is the least damaging just in the small part of the ventricle versus grade 4 is bleeding in the brain, the tissue, and the ventricles. When we have the baby, again, we want to promote their growth and development. So a lot of times we'll call these babies feeders, growers, because again, we want them feeding and growing. We want to make sure that we give them the temperature support that they need. So if they have to stay in an isolette, again, and only coming in every 3 hours to do everything clustering that care. So we do their assessment, we do their, their feeds, and then let them rest. They can kangaroo care with the baby. It helps keep their body warm, it helps to regulate their heart rate and their respiratory rate, helps them to gain weight, it helps them go into deep sleep. And so again, they have a better chance of survival there. We also have our post-term infants, so again, higher risk like we talked about before of meconium aspiration. We want to make sure we have that suction available at birth, and they can need ECMO again for that as well. All right, nurse's note says that the postpartum client is RH negative and the RH positive mom. What maternal lab should the nurse review next in determining if the client's a candidate for RhoGAM? Hemoglobin, direct Coombs, indirect Coombs, or bilirubin? Not B. A. Not A.
C.
C. Yeah, understand the body's in the All right, so there'll be a